Well, it's great to be here. This is my first time actually on USC's campus, and I'm really looking forward to getting to know all of you, catching up with Heather, and in particular getting to know our GlobeMed chapter here on campus. If Teddy, who's a classmate of mine, as Heather mentioned, is representative of the work that's happening at USC, you all are in damn fine hands because he's wonderful. And my remarks today are going to really focus on some of the work that I've been doing with GlobeMed and how I think about student engagement in particular at the undergraduate level on college campuses. But recently, in particular, Liberia has been very much on my mind, and I've been working with Partners in Health and Last Mile Health to think about how we can respond to the crisis. And so I'm more than happy to talk about that afterwards. And I hope to the extent that is possible, this can very much be a conversation. You all know just as much about undergraduate engagement and university engagement as I do. So feel free to interrupt with questions or disagreements, and we'll take it from there. Does anybody know what this title is in reference to? I don't know to what extent people are familiar with Austrian philosophers. So this is great, because I was worried people would have all been familiar with this. So this is actually a quote from Ivan Illich, and he he was an Austrian philosopher and a Roman Catholic priest, and was a fairly well-known social critic, in particular on Western imperialism and the way in which Western societies were influencing other communities, marginalized communities around the world. And this phrase, "to hell with good intentions," came from a speech that he was invited to give in 1968 in Mexico. There were a number of American students who had gone over to Mexico to engage in these short-term projects for 4, 6, 8 weeks in the 60s. And they had known that Ivan Illich had been a strong critic of that type of work, but thought nonetheless it would be a good idea to bring him over. And sure enough, he ridiculed them for 15 or 20 minutes in front of their face, saying, to hell with the work that you all are doing. You're creating more chaos and disorder than you are service and benefit to the communities that you work in. There were a couple good lines in his speech that I wanted to read. Well, he chastised them for imposing their benevolence on Mexico, thinking that without a strong sense of the local languages, the indigenous languages, without a strong sense of the community, that they would be able to provide any meaningful service. He chastised them for bringing in their Western values, the Western middle class as being the standard upon which people should be striving for in communities around the world. He also ridiculed groups like the Peace Corps, who would spend $10,000 per Corps member at the time, I don't know what it is now, training their Peace Corps members in cultural sensitivity and orientation to try and lessen the impact of cultural shock, sometimes people say. And he said, how odd that nobody ever thought about spending money to educate poor Mexicans in order to prevent them from the culture shock of meeting you. And he quotes this saying, which is an Irish saying, but also a theological one, that the road to hell was paved with good intentions. And this was 1968. And one of the things that I'm really hoping to reflect on with you all today is how much has changed since that time. If we look at just the numbers around student study abroad experiences, students and universities seem to be saying to hell with Ivan Illich, that we've seen nothing but an increase in study abroad opportunities. And the red on this graph in particular is the increase in short-term student engagements abroad. And so those are defined as 4, 6, or 8 weeks, whereas the long-term, whether it's 6 months or a year, have largely plateaued. So the trend in the field seems to be continuing towards these short-term engagement opportunities. And this has been in tandem with growth in the global health field. And we could talk for days about kind of the emergence of the global health field over the past couple of decades, and really with our generation, the experience of 9/11 and Skype and modern communication. We're living in a much different world than generations prior to us. And we've seen that university programs across the country are trying to meet that need by starting undergraduate tracks in global health, medical school tracks, in global health. This is from a report that was done by the Center for Strategic International Comparative Studies, I think is what they're called, and of all the 35 respondents that had replied to their survey, all of them had global health programs. More informal studies from the Consortium of Universities for Global Health and other organizations have suggested that there are probably about 70 or 80 undergraduate tracks in global health. And at med schools, I think there are 131 med schools across the country, and more than 100 of them have formal global health programming. So students are going abroad, universities are trying to meet that demand as it relates to global health, and I, with my colleagues at GlobeMed, really for the past couple of years have been thinking about whether or not we as students can engage in a way that's responsible and impactful in global health work. And you know, I think there are a number of positive examples out there, but certainly there are a number of examples where we haven't gone much beyond the programs that Ivan Illich was critiquing back in the 1960s. And so I thought I'd start off with the examples of the bad rather than the good, and rather than critiquing others, I figured I'd critique myself and talk a little bit about some experiences that I had as a college student at Northwestern. And these were some of the experiences that, along with those of a number of my peers, really informed the work that we were doing with GlobeMed. But so as a freshman at Northwestern University, this was in 2006, Northwestern actually had a undergraduate global health minor at the time, and so I was able to get involved in some of those courses, learn about the academic side of global health, learn about a number of the very daunting and startling global health challenges that our world was facing. But then I wanted to do something about it. I didn't want to just sit there and learn and take the prescription that a number of my professors and others had said, which was go study hard and go to med school or go to nursing school or do whatever it may be, and then 5, 10, 15 years from now you can actually be an effective actor in the field of global health. For me and a number of my friends at Northwestern, that wasn't an acceptable response to what felt like an urgent moral calling. And so the opportunity that we had access to was one that I believe she was a junior at the time at Northwestern, was organizing, which was a medical relief trip to take about 4 doctors, 8 medical students, and 8 undergraduates to Quetzaltenango, Guatemala for a week to set up clinics and you know, come in with our duffel bags of medicines over our shoulders and try and do what we could in the rural highlands of Guatemala for a day or 2 at a time. And it was an interesting experience. I saw, I think from a public health perspective and a clinical perspective, more daunting challenges than I had ever seen before. These were communities that had been pushed by transnational corporations into the highlands in these arid lands where people couldn't cultivate crops, people didn't have homes, they were depending on, you know, shelters from USAID to have even basic rights like the right to shelter. And here we were as a group coming from the outside trying to alleviate some of that suffering. And the group, we would translate from Quiche, the indigenous language, to Spanish, and then to English, and then back from English to Quiche and to Spanish, and then Quiche. We would see probably 200-300 patients in a single day, often just give out multivitamins, maybe antibiotics, sometimes make referrals to, you know, the hospital in the city, and then left. And that was it. And there were a couple of us who returned from that trip feeling very unsettled by that experience. The more we reflected on it, the more it felt to be a experience that was geared towards us as volunteers rather than for the community that we were trying to serve. And you know, like we were in clinical settings that as at the time I was probably 18, maybe 19, would never be allowed in the United States or any other Western country. And it really was taking advantage of a vulnerable community and allowing that to be an opportunity for a number of us to have more hands-on clinical experience. And so around the same time, a number of us were reflecting on how then can we do better? And there were a number of Northwestern students who were involved in supporting a clinic in Ho, Ghana, in the eastern Volta region of Ghana. And we were trying to reflect on the previous experience in Guatemala, that it couldn't be about short-term trips rather than spending. We probably spent in Guatemala $20,000 or $30,000 amongst the crew of us to buy the flights and to rent the hotels and get all of the medical supplies. And so why not just send that directly over? And so through some connections between different Rotary International chapters, one in Evanston, Illinois, the other in Ghana, we ended up, and a number of other folks ended up raising about $20,000 or $30,000 to send over to Ghana to a community leader who we had suggested that they go ahead and build a clinic. And it was about a year after that Victor Roy, who I would later work hand in hand with to build GlobeMed, Victor ended up traveling to Ghana and arrived at this center called the Hope Center, and it was empty. It was an empty clinic. There were no staff, there were no supplies, there was no activity, no health services. And Victor spent a lot of time with the community leader, Joseph Achana, trying to understand what had happened. And Joseph said a very simple phrase that I think has resonated with a number, has really informed a lot of the work that we've done moving forward. He said, Victor, we're African, we listen to our donors. And they had been told to build a clinic. And that was then the priority, to get the clinic up off the ground, regardless of other services were being provided, regardless of whether it was in an area that was really needed. And we ended up working with Joseph and others following this trip to forge a partnership with the Ministry of Health and some other actors. So now it's actually a functioning clinic. But here again, we had prescribed an understanding of what was needed, a clinic, from afar, and sent the money over thinking that that would lead to, fantastic results. And what ended up happening was an empty clinic. I think both of these are examples that Ivan Illich, were he alive today, would hold up as reasons where American students coming from abroad with ideas of how to serve or where to serve go awry and end up wasting money, causing chaos, causing disorder. With coming out of Guatemala and then later Ghana, Victor and I were, and some other folks at Northwestern, were asking some big questions about whether or not we should be doing anything at all. Maybe the path was just investing deep into our studies and coming back to this work later. But it was actually through conversations with Joseph and other grassroots leaders around the world and other students across the country that we started to identify areas of synergy where, if paired properly, grassroots health organizations and students could actually be quite impactful partners, with the grassroots organizations being the ones who know what's happening in the community, know how to provide frontline services, know the politics, know where to build clinics and how to forge those relationships, but sometimes not having all of the funding that they need to do that. A number of the organizations that GlobeMed now works with today do not have the connections that a lot of international NGOs, like Last Mile Health, like we do in Liberia, to be getting the USAID grants and the DFID grants and all of the big international NGO grants. Yet with $15,000, $20,000, $30,000, they're fundamentally transforming their communities for the better. And so as students, we are uniquely positioned in arenas of great wealth. Look around this campus, whether it's the institutions themselves, whether it's the assets of researchers or faculty members, alumni networks, our own campus networks, we have access to an unbelievable amount of resources. And so how do we pair those two together in a way that allows these grassroots health organizations to thrive, and for where possible and appropriate for students to learn from that and have not just abstract lessons in the classroom about grand global health challenges, but really understand how that's translating on the ground. So with GlobeMed, and these are kind of some of the early notes that came out of those conversations with Joseph and others. But with GlobeMed, we started asking those questions about what it looked like to go from a volunteer-centric model to a community-centric model, from having presumptions of what's needed in communities halfway around the world to really engaging humbly and with curiosity with partners and leaders who are doing the day-to-day work. And for us, where we've tried to hone that focus is on the partnership. It can't be about just the students acting on their own. It can't be about the grassroots organizations. It's about figuring out how two communities separated halfway around the world from each other can really work together to support one another in a mutually beneficial way. And I do believe, and I'll talk about a couple of examples from GlobeMed, but I do believe that when done right, we can do so much more than the prescription of chaos or disorder that Illich initially mentioned. So just to give you a better sense, and I would love if the GlobeMed folks here could talk a little bit more about this after my presentation, but there are kind of three basics to what our students are thinking about on a daily basis. One is how they can mobilize the wealth of resources that we have access to on our university campuses to be supporting these organizations that will do great things with the money. The second is learning from that experience. So both to better inform the work that they're doing that year, that day, but also to better inform who the education of these people who we hope will be amongst the leaders of global health in the future. And then we do send students abroad for 6 to 8 weeks to visit with their partners, but that is less about the on-the-ground service and more about building that relationship so they can be strong advocates when they return. But there have been a lot of really high-impact things that have come out of that time together on the ground, whether it's media projects, websites, trying to forge relationships between different organizations that has given access in new ways to these grassroots leaders that otherwise they hadn't had previously. Two examples of what this translates to. This is a photo from Togo, an organization called Hope Through Health. They're doing work in the northern part of Togo to provide community-based HIV treatment services in a part of the country where previously people would have to walk impossible distances to get to the nearest health facility. And they're partnered with our very nerdy chapter at MIT. And the MIT students are whiz kids. They're amazing. And they know technology and IT systems far better than I ever will. And what they've actually done is they've leveraged that expertise that they have, that MIT has, to be supporting the IT infrastructure for Hope Through Health in Togo. And so they've done kind of the typical stuff, the ordinary stuff that you hear about in a lot of these programs, like donating laptops and computer training. But they've even gone as far as to develop a tracking and procurement system for the medicines that the clinic is using. So now they can better predict stockouts and forecast the supply of their medicines. And the Hope Through Health team raves about the work that the MIT chapter has done. They value it amongst their partners that are donating 10 times the amount that we are because of this type of on-the-ground support. This is a map that was designed by some of the students from our chapter at Middlebury College, and this was done for an organization called Gardens for Health, which is providing nutrition services for women affected by malnutrition and HIV in Rwanda. And what the Middlebury chapter did, in addition to raising more than $30,000 over the past few years to support the general operating services at the clinic, was they leveraged a few students in particular who had been studying how to use GIS systems to map and track patients and services. And so they ended up going out and working with some of the GHI health workers to map where all of the different recipient families were of GHI's programming, and then they overlaid that with the health status, the dietary status of the family members in that community, so the organization could then better track where the communities were that needed additional services, or where the health workers could be performing a bit better. Two of the students at Middlebury who were actually involved with this project have since gone on to found an organization called Broad Street Maps that is trying to do this for grassroots organizations around the world. This was a quote from one of our partners who said, GlobeMed students are different. They don't just send money, they practice solidarity. They come to work together with us, sharing ideas and brainstorming, but in the end, they always respect and support our decisions. And this captures so well what we're trying to do. And as with all organizations, we are imperfect, and I'm sure that it won't be every person who says this about our work, and I want to be very upfront about that, but this is exactly what we need to be striving for, not just for GlobeMed and our partners, but I fundamentally believe as we think about international development and global development, this is the type of attitude that needs to be cultivated. So how is this all possible? It comes from a bedrock of a good deal of training and support and advising. We have taken previous GlobeMed chapter founders and staffed them as chapter advisors. So on a weekly or bi-weekly basis, the chapter advisors are talking with the chapter leaders, helping them to improve their programming, improve the partnership. We bring together students on an annual basis for a leadership institute and a summit, and where possible, we leverage, the expertise of existing students. It's a low cost and kind of high impact way to bring quality advising to scale. But we invest in this because what we've seen in the past with other organizations and what we've at times struggled with ourselves is that the willy-nilly free-for-all approach doesn't work. That building effective undergraduate or student leaders in global health requires training and mentoring and advising, and oftentimes that's not the type of skills, those aren't the type of skills that are being provided in the classroom. The classroom is more of a academic or educational approach to understanding these issues and less about the ultimate delivery of services and working with people. And so what we try and do is complement that to make sure that all of our partnerships and chapters remain at a very high quality. What we've found over the years is that there's a great interest for this type of model across the country. We've recently expanded to 56 campuses across the country that's paired with 56 partners around the world in 17 countries. And one of the exciting things that has come out of this is that we've realized that there's opportunity as we grow to not simply bridge connections between students, but also bridge connections between grassroots organizations. And so this past year, we actually, for the first time, brought together all of our partners in East Africa with the support of from a group called the Segal Family Foundation that's thinking very progressively about how to be supporting organizations of this size. And we brought together some of the GlobeMed students as well as some of our partners to talk about to share best practices, both as it relates to their work with GlobeMed, but also just as organizations trying to tackle similar challenges. So this is kind of summing up how we think about our work at GlobeMed. It's about investing in students. It's about really figuring out how to partner and make a real impact with grassroots organizations around the world, and then taking advantage of this, in some ways, unprecedented network that we're trying to build between students in the US and grassroots organizations. And again, not just from students to organizations, but also between organizations and between students. Moving forward, I just wanted to offer a couple thoughts on how I think about the role of universities and students in global health. And this is in particular where I'd love to hear people's thoughts on afterwards as well. While I feel good about the work that we're doing with GlobeMed, it's come from a lot of muscle and a lot of accountability systems that we've put in place as an organization to help ensure that students, when going abroad, students when partnering with grassroots organizations, are doing it in a way that upholds the values that we strive for. But not everyone does that, and like I said, we're also not perfect. And I think there's a real role to play for students and university faculty, for administrators, and I think most of all for grassroots organizations to start a conversation about how we can develop across organizations, across partnerships, a core set of principles. There have been a number of folks who have started to write about this in the academic literature, which I think is a promising start to try and identify some principles for global health training programs. But I think what it's actually going to take is something more similar to the NGO Code of Conduct. This is something which you should all check out. It was done by a number of organizations who, over the past few years were overwhelmed by the proliferation of NGOs and witnessing the way in which in places like Haiti after the earthquake, or really just about any country in the world, that's stripping the most talented people from the public sector, from government institutions, and putting them in organizations that don't have the same type of commitment or obligation to be serving the people of their country. So what the NGO Code of Conduct is trying to do is get different signatories to sign on to this and establish a core shared set of principles around poaching staff, around compensation, things of that nature, to ensure that we don't suffer from this internal brain drain of the most talented folks in the public sector going over to private NGOs. Something similar is needed for thinking about student engagement in this work. And I've heard that some people are starting to think about this, and I hope that as we do this together, we can bridge the student perspective, the university perspective, and the perspective of grassroots organizations, and then figure out a way to use it. Jess Everett at UCSF is working with faculty all around the country to think about how med school admissions processes can start to distinguish between the work that I did in Guatemala versus the work that, say, GlobeMed at MIT is doing in Togo. Very different experiences, but can, as happens so well in med school admissions processes, really be twisted or spun in the same way. And so how can admissions committees be thinking about something like this as well, to help judge which organizations are ones that are doing the type of work that they respect? Training programs. So as we've grown training programs over the past decade at all of the universities around this country, there is an overwhelming focus, as is like the mandate of these institutions, to be investing in their students. And the risk there is that the partners abroad, partners in Togo and Liberia, become objects for experiences and learning rather than true partners to be tackling some of these challenges together. For every one student who's interested in global health here at USC, there are a dozen or 2 dozen students in Liberia and Rwanda and elsewhere who are eager for that same type of education. So how do we honor the integrity and really respect that experience, that shared experience, and how we design training programs even here in the US? There's an organization which some of you, I'm sure, are familiar with, based out of Indiana University. It's called the AMPATH program, and they've formed a partnership with a teaching and referral hospital in Kenya, and they've, from the start, committed to, for every student that goes over and trains in Kenya, that they'll also take a student to Indiana from Kenya. And these are the types of programs that are actually going to build the type of world that we're trying to create. Pharmaceutical research and access. Is anyone here from UAEM, Universities Allied for Essential Medicine? All right, well, you're all going to learn about them today. And I think there is a new chapter starting, or there's some undercurrent of UAM at USC. UAM published last year a global health impact scorecard that was looking at how research that comes out of universities like USC and public universities across the country is being done in a way that guarantees access for populations that otherwise wouldn't be able to afford it. And so they try and leverage their power as students to ensure that universities sign on to certain types of licensing agreements and things of that nature. In particular, when there's federal funding, a lot of the funding at institutions like USC and elsewhere is public money. It's money that we're paying for as taxpayers, and ultimately these patents end up getting sold to pharmaceutical companies that then reap great profits off of these what are really public discoveries. So UAM is trying to put pressure on universities to be as progressive as possible with that. They put together this scorecard in which they found, they were looking in particular at neglected tropical diseases and found that less than 3% of research in 2010 was devoted, at the top 54 universities, was devoted to research in neglected tropical diseases. There have been a number of universities, 21, that have endorsed socially responsible licensing agreements, but 4 only actually say what that means for them. And so it's difficult to hold institutions accountable unless they're really explicit about what that means. So I thought I'd end just with a brief story which is related to UAM that I hope speaks to what Ilish was saying with to hell with good intentions. I'm just going to have a sip of water. So I'm sure many of you have studied the HIV epidemic. This in particular, the story in particular is focused in 2000 in South Africa, when at the time 500,000 people were in need of antiretroviral treatment. We had the drugs as a global community, but only 1% of people in South Africa could access those, and that was because of money. At the time, there was a very potent antiretroviral called D4T, which cost $1,600 US dollars for a yearly course of treatment. And the average GDP for most South Africans was $3,000 at the time. So it's an impossible burden to take on. So what happened at the time was actually really interesting, because the South African government followed the suit of the Brazilian government, which said, this is a national emergency, and screw your pharmaceutical patents. We need these drugs because our country is literally dying. And so the South African government said that they were going to leverage an international agreement that said they could generically produce the intellectual property of the manufacturer of D4T, which was Bristol Myers Squibb. And when they couldn't produce the sufficient quantities, they could also import from countries like Brazil, which had established this type of clause previously and access these drugs at a much lower price than $1,600 for a year. Bristol Myers Squibb wasn't pleased with this, and rightly so. At the time, just in the year 2000 alone, they had made, let me make sure I get this right, $578 billion in sales from D4T. And so they actually, and there was initially support from President Clinton, but he later thankfully withdrew. They had filed suit, a lawsuit against the South African government. Now, mind you, this TRIPS clause in international agreements is one that the United States has leveraged in the past. In the aftermath of 9/11, when there was the risk of anthrax as a tool of terrorism, and 4 people, I think, at the time had come into contact with anthrax, we leveraged this TRIPS agreement, and no one complained then that the United States was doing it. But suddenly, when you're talking about South Africa and talking about, $570 billion worth of profits, it's a much different story. So, there was a first-year law school student at Yale who caught wind of this. She was an HIV activist and ended up identifying that the license for D4T was actually created in the 80s by a Yale researcher. And it was Yale that had then sold an exclusive licensing agreement to Bristol Myers Squibb. So the law student's name was Amy Kepczynski, who's now a professor, and she mobilized her classmates. She said that this wasn't acceptable, that Yale couldn't stand by as hundreds of thousands of people died because of research that came out of the institution that was being withheld during a public health emergency. So they had organized themselves and had requested that Yale deny that exclusive licensing agreement. And Yale said no. They weren't going to do it. And why weren't they going to do it? Because they were also making a hell of a lot of money off of it. At the time, Yale was making $40 million a year off of D4T, and that represented just about all of their pharmaceutical royalties that were coming in. So, of course, they said no as well. But Amy and the students she was working with were not satisfied with that answer, so they protested. And Yale still said no, and so then they petitioned. Yale still said no, and then they were able to bring in the media. They actually had the researcher who initially discovered the drug write an op-ed for the New York Times, really raised the profile of it, and eventually they succeeded. They got Yale and BMS to together declare that they weren't going to uphold the exclusive licensing agreement, and that South Africa was permitted to go ahead and produce this drug. And within a matter of months, the price dropped. The price for D4T, which was $1,600 a year, dropped 96%. And was that exclusively the result of Amy's work and the students at Yale? No, it took researchers, the researcher who wrote the op-ed, it took the negotiations between Yale and BMS, but Amy and her colleagues there held the fire to Yale's feet in a way that I fundamentally believe advanced that process along in ways that wouldn't otherwise happen. So that's something that I think even Ivan Illich would be pleased with. So thank you for having me here, and I look forward to the conversation.